ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಸ್ಟಾರ್ಟಿಂಗ್ ನಲ್ಲಿ ಅದನ್ನು ಶೇರ್ ಮಾಡಲಿಲ್ಲ. ಎಸ್ ಸರ್.
Yeah, so hi everyone, this is Dr. Juhul Patel. I'm consultant gynecologist and laparoscopic surgeon practicing in Hyderabad. Just a brief introduction. I have a training center in Hyderabad and I have a training center in Aurangabad that is located in Maharashtra. So we routinely train around like more than 150 gynecologists per year. Okay, that the course will be like hands-on for laparoscopy. Now, focusing into the AYUSH doctors. See, AYUSH doctors, I always feel like you people are like, bridging gap between the community and medical fraternity. So always I wanted to have something like this where we can get connected to the AYUSH doctors. Okay, now what I can see is like all of you have passed your Ayurveda or homeopathy or Unani medicine. Okay, so what we wanted to educate you about laparoscopy, what is going on in the field of gynecology and in the field of general surgery. Okay, so coming to the this thing laparoscopy. See, laparoscopy is like in traditional way we used to perform surgeries. Like in let's say in general surgery we used to do hernia surgeries, like open surgery where we used to put like big cut around 10 to 12 centimeter cut on the abdomen. Okay, and then we used to do like all type of surgeries. And coming to my field, I am basically gynae onco. Okay, so coming to my field, we used to perform gynae procedures or we used to perform oncological procedures by giving a big cut. Okay, that will be around like depending on the size of the tumor, but that will be around 10 to 12 centimeter cut on the patient's abdomen. Okay, and from 2005 2006 this complete scenario has been changed, like with the advent of laparoscopy. Now what is laparoscopy? Laparoscopy is nothing but like doing the same surgery, okay, but not like giving the like 10 to 12 centimeter cut, but doing the same surgery in the minimal invasive way. What will be the minimal invasive way? That will be not giving the cut to the patient of 10 to 12 centimeter size, but it will be micro cuts. What we mean by micro cuts is like giving like 1 centimeter cut, and where we put like camera inside the patient's abdomen. Okay, and we'll be operating with the like operating ports. What we call it as like that will be like around 5 millimeter, that is 0.5 centimeter. Okay, so the entire procedure gets over with hardly like 1 centimeter cut. The benefit of the same thing in patient would be because the cut size is smaller. Okay, patient's recovery is much faster. Okay, again, because the cut size is smaller, okay, the patient pain in recovery, okay, will be like tremendously reduced. So just giving you an idea, like previously in open surgeries, a patient used to stay in hospital for like more than 7 days 10 days. Okay, but now with the advent of laparoscopy, sorry, someone just called, sorry. So with the advent of laparoscopy, the entire procedure we finish it off like in like 1 centimeter cut. The benefit, as I told, like fast recovery. Okay, the pain will be reduced, and at the same time, for cosmetic reasons, the patient won't even like see the cut on the abdomen. Okay, so now something called as like we do it the skin stitching in the subcuticular way. So in that, like patient doesn't even like see the cut on the tummy. The best benefit, what I would say in laparoscopy over the open surgery would be because the cut size is smaller. Okay, one, the patient is getting benefited because the cut size is smaller, pain is less, recovery is faster. And at the same time, as a doctor perspective, see, our eyes have a zoomed vision of only 2x. Okay, whereas in camera where we operate, the zoomed vision will be like a 4x or 8x. Okay, depending on the system what you use. Okay, with the 8x vision, okay, always the precision is more when it comes to a doctor. Okay, so always with doctor, the benefit is the vision is better, so that they can do the microsurgery. Okay, with the what do you say, zoomed vision. And with patient, the benefit would be like faster recovery. Okay, so rather than wasting your time, let's jump on to the direct presentation, what we have prepared. Hello, you can go ahead with presentation. So the entire course, what this course is about, will be briefing you about how the laparoscopy is done and how we do the laparoscopic surgery. Okay, in the presentation, you will come to know that I won't like take you to the much deeper into the theory, but I'll tell you the more practical aspects. Hello. 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 Is anyone there?
Hello, sir. Dr. Hussain is available, sir.
Yeah. Please take us to the presentation. No, forgive me because like all this Ganpati Nimarchan is going on here. I am in Hyderabad. So all the sounds, even if I reduce all the sounds, then also I cannot reduce like much of the sound.
Okay, sir.
It started, sir.
Okay, sir.
Yes. Can you full screen it? The presentation? Can you start the slideshow?
Yes, sir.
Yes. So this is the initial introduction, what I've given of myself. Now coming to the first slide, that is what is laparoscopy. First slide.
Not the first alpha means how much, sir? 110 sheet?
Go on the first slide. Second slide. Yeah. So that's what I meant. Okay, what do we mean by laparoscopy? Laparoscopy literally means to look inside the abdomen. Okay, not by cutting the abdomen, but putting a camera, because we have advanced technology now. So we are not cutting the abdomen to the fullest, but we are putting only 1 centimeter cut to let the camera enter inside the abdomen. This is the exact way, okay, how we perform the laparoscopy. This is just a pictorial representation of the same. Okay, next slide. Yeah, this is like the history of laparoscopy. Like grossly speaking, it has been started in Germany, but when it comes to laparoscopy, now India is far better. If you compare Germans and if you compare Indians, Indians have become far better. Though they have invented, but out of practice and out of doing, we have become much better. Okay, so I'm not going to go into the history of laparoscopy. Go ahead, next slide. Now, grossly speaking, I'll tell you the gross idea. See, inside the abdomen, when you put a camera, okay, there is no light inside the abdomen. So, simple logic, we have to put a light by machine. Okay, the machine which gives us light, we call it as light source. Okay, second thing is inside the abdomen, there is no space. Okay, so we have to create a space by something called as insufflating pneumoperitoneum. Pneumoperitoneum is nothing but we insufflate some amount of gas inside the abdomen. Okay, when we insufflate gas inside the abdomen, what happens? Abdominal wall gets lifted up. Okay, when abdominal wall gets lifted up, all the vital organs, when I say vital organs, what I mean by vital organs are like there are intestines. Okay, there is urinary bladder, there is rectum. Rectum is like where we store our feces. All these vital organs, when we insufflate gas, okay, all these vital organs are separated and they go down. Okay, and you get some space to operate. So the machine which gives us this space, machine which gives this pneumoperitoneum, what we call it as insufflator. So in laparoscopy, one is camera. Okay, that is going to give you picture. Okay, second, inside the abdomen there is no light. Okay, so the machine which gives us light, we call it as light source. So second machine which goes with camera is light source. Okay, third machine inside the abdomen, see, as I told you, there is no space. So we have to create a space by insufflating pneumoperitoneum. Okay, the machine which gives us constant pneumoperitoneum, we call it as insufflator. So just remember, in laparoscopy, three machines always goes together. One is camera, which gives us picture. Second is light source, which gives us light. Third is insufflator. That gives us space and that gives us constant pneumoperitoneum. Okay, so coming to the slide again, why laparoscopy, previous slide, please. Again, previous slide, not next slide. Previous slide. Again, previous slide, not next slide. Yeah. Yeah. So why laparoscopy? As I already told you, advantages of laparoscopic versus open surgery: less post-operative scarring, reduced pain, less time spent spent by the patient in the hospital to recover, reduced hemorrhage. All these things are happening because we are doing the surgery in the minimal cut. Right now, as I told you, the theory. Now coming to the practical, how the machine, all this machine looks like. Okay, coming to this next slide. Okay, this like all these machines, how it looks like. One is camera, one is light source, and one is insufflator. Okay, so whenever you being a AYUSH doctors, whenever you enter in OT, okay, whenever you see something like this is what we call it as laparoscopic trolley. So in laparoscopic trolley, three machines you will always find. One will be camera, one will be light source, one will be insufflator. Okay, and the camera will be connected something called as monitor. Okay, so that's all you can see in the screen, right? Next slide, please. Okay, so as I told all these things, laparoscopic surgery is a keyhole surgery with the small incisions are made in the abdominal wall. Okay, coming to next. Next slide. Okay, this is the way. Okay, this is the way we put a camera inside. This is the way how we put a light inside, and this is the way how we put a gas inside. Once we put a gas inside, you get the space. Okay, and light source will give you constant light. Yeah, right. Next slide. Yeah. So the same system, the same thing I think I've mentioned. Sorry, pardon me for all these things, but Ganesh, Nimarchan, I cannot do anything. Okay. So the same thing I told you already in theory. Okay. Light source, light cable, telescope, camera. Okay. Video monitor. Right. This is the imaging system. This will create the image. So when you see machine like this, you can see in the right side of the screen. Okay. That is camera. Okay, so camera is nothing but it is same like a mobile camera. How in mobile camera, when you record a video, okay, different cameras will give you different resolution. Like Samsung mobile camera or Apple mobile camera, the picture quality will be different, right? So there is something called as German, because Germans they started this thing. Okay, so this is German. One company is there, Karl Stoss. They make the what do you say, laparoscopic camera. But in India also, we have started producing the same type of cameras. So it is nothing but same like a mobile camera. Okay, so this is nothing but what they are showing you on the screen is the camera. Okay, so camera will be connected to the monitor. Apart from that, there is nothing. Don't get confused when they tell you like it is like camera. It is not a high fundu camera. Just consider it like a same like any other mobile camera. Okay, so this is camera. We are just showing you the photos. So next time when you enter in the OT, you don't get like, like some high fundu surgeries is going on. Laparoscopy is not a high fundu surgery. Laparoscopy is just the different way of doing the same surgery, right? Next slide. So coming to the light source, as I told you, first is camera, which give you picture. Okay, at the same time, we require light inside the abdomen. So the machine which gives us, we call it as light source. Okay, so don't get confused again with the light source. See, in light source is a machine. It will be like a box. Inside the box, there will be one bulb. Okay, that bulb will be constantly emitting the white light. Zishan, can you convert this thing, your screen to my screen, please? Hello,
Sir,
Zishan.
not happening, sir.
Not happening. Okay, leave it. So coming to the light source, it is nothing but a one machine. Okay, one machine box. Inside that there will be one bulb. Okay, as it like in your all your houses. Okay, there will be one bulb. Okay, which will be emitting white light. Okay, so inside this machine there is nothing big high fundu thing is happening inside. Inside that machine we have just kept one bulb which will be emitting white light. Okay, now to operate any laparoscopic surgery, to let it be gynec lap surgery or let it be general surgery lap surgery, any lap surgery, we can operate with minimum. Okay, see, inside your house, one bulb will be there. That bulb will be emitting the light at 20 watts, right? So inside the abdomen, how much quantity of light do we require to operate without facing any difficulty? Okay, so coming to the light source, okay, because I am only the manufacturer of the light source, now I can say that machine, okay, in that where there is a bulb of 120 watt, okay, inside your houses, okay, you will be having some LED bulbs and all. Okay, that LED bulbs, what we use it for the commercial purposes or home purposes, okay, those bulbs emit maximum at 40 watt, 50 watt. To perform laparoscopic surgery, we require bulb of minimum 120 watt. Okay, so grossly speaking, in entire world, there are two bulbs which is emitting white light. One is xenon bulb and one is LED bulb. Okay. When it comes to the marketing, xenon is 3 times more costlier than LED. So, simple language, all the German manufacturers, they make the machines, light source machine with the xenon bulb, whereas all the Indian manufacturers, because of the cost issues, okay, we make all our machines with LED bulb. Okay, so let's not go much deeper into the theory, but light source is nothing but which gives us light. There are two types of bulb. One is xenon bulb, one is LED bulb. Both does the same purpose. That is giving us the light. Okay, so that's all. I think I have covered. Next slide. Yeah. So the statement would be the good laparoscopic light source should emit the light as much as possible near the wavelength of natural sunlight. So let's not go much into theory, but just understand that light source is nothing but which gives us the white light. Okay, so the same thing. See, typical what I told you. The typical light source consists of a lamp, heat filter, condensing lens. Again, let's not go into that. But light source is the machine which gives us white light. Okay, next. Three types, as I told you: xenon, halide, vapor arc lamp. This all are theory. We used to use it before, but now we are not using. Okay, next slide, please. So this is how we manufacture. Again, you people are never going to manufacture it, so forget about it. Okay, next slide. Okay, so as I told you, two most frequently used type of lamps are halogen and one is xenon. Okay, this halogen in India, now we have replaced it with LED. Okay, halogen is that yellow bulb. Okay, now we have replaced because halogen is yellow. We used to get a yellow picture, but we want some white picture. Okay, so we have replaced this halogen bulb with the LED bulb. So the most frequently used type of lamps in India is xenon and another one is LED. Yes, go ahead. Next. Okay, so light source will be emitting light. Okay, now what we have to do is we have to throw the light inside the abdomen. Okay, the cable, okay, which does that, we call it as light cable. Simple. Okay, next slide, please. So this is like a light cable where it will get attached to one machine and another end will go inside the patient abdomen. Okay, it is nothing but it will be conducting a light. Simple. Okay, so let's not go deeper into the physics of it. Next slide, please. Okay, the same is called as fiber optic cable. Yeah, next slide. Yeah, this is how it looks like. So the whole purpose of this conducting this seminar is not like next day only you are going to go and perform the surgery. The whole purpose of doing this is like whenever you enter the OT next time, okay, you won't be like completely new to all the system. At least like you will be able to know the names. Okay, this is how fiber optic light cable looks like. Yeah, please go ahead. Okay, there is yeah. So coming to the laparoscope. Now, as we discussed, that camera, okay, creates an image, but we want something to go inside the patient's abdomen. Okay, the thing what goes inside patient's abdomen, we call it as a laparoscope. Okay, again, let's just we'll keep it simple. That one instrument is there, okay, which will go inside patient's abdomen. We call it as a laparoscope, which will get attached to the camera. Okay, let's go to the picture of it. Yeah, next. Yeah, next. Yeah. So depending on the type of surgery, there are like different diameters of laparoscope. Again, 1 centimeter, 5 millimeter, less than 5 millimeter. There are like in India also we have started manufacturing like it's very nice thing that we are not doing anything now, like comparing with the Trump's tariff and all. Okay, we are only manufacturing all these things. So coming to next slide, please. Yeah, lens system. Next. Yeah, so this is how laparoscope looks like. Okay, next. Yeah, so here you can see like this is the camera. Okay, this is the camera. In front of the camera, that laparoscope, what I just told, that is going to get attached, and the whole system with attached light source. Okay, it goes inside the patient's abdomen. Okay, so what you will get all three together. Okay, one will be camera will be attached to the light source, so light also will go inside. Okay, the whole system will be attached to the insufflator. Insufflator will maintain the constant pressure inside the abdomen, right? Go ahead. This is all theory, but I just want you to walk through all this theory so that when it comes to a practical this thing, I'll definitely take you to the practical surgery also. But theory is very important to build a practical base. Okay, there is something now, as I told, laparoscopic video monitor. Video monitor is nothing but a same like your TV. Okay, so what I can say is like, see, if you purchase a TV, okay, you cannot directly start watching the TV shows, right? You have to purchase the Wi-Fi also, or you have to purchase some setup box also. So setup box will be like your camera. Okay, TV is just the projection of what your setup box is going to offer, right? So it is just the video monitor which projects what camera is going to project it, right? Next. Pneumoperitoneum, everything I told. Next. Yeah, so coming to the creation of pneumoperitoneum, there is something called as trocars. It is nothing but it is a sheath, okay, which will go inside the sheath. You are going to put your instruments. Okay, so creation on pneumoperitoneum, we use something called as Veress needle. Okay, I'll be explaining you with the video. Next, please. Yeah, next, please. This is Veress needle. Veress needle is nothing but the tip is blunt, and Veress needle is used to create a pneumoperitoneum. So when I take you through the video, then you'll understand more of theory. Next slide, please. I think I've attached one video. Zishan, I've attached one video. Directly jump onto that slide. Yeah, next. Next. Yeah, this is how Veress needle looks like. Okay, so this is nothing but this is the first step of doing the laparoscopic surgery. What we do is nothing but take this instrument, we put it inside the patient's abdomen, and one side will go inside patient's abdomen, other side we connect it to the insufflator. So when we connect it to insufflator will like blow constant gas inside the abdomen. Okay, so this is how what I wanted you guys to know is like how Veress needle looks like. Okay, so this is how it looks like, how to put it, and how we go before the surgery. We can go to the next slide. Practical aspects I'll like cover when go to the next slide, please. Next, how to put a Veress needle. This is how the insufflator looks like. Okay, so in the insufflator you can see there are some parameters like first column, second column, third column. Okay, where we maintain constant abdominal pressure. Okay, when we like when we insufflate the gas, we want the gas to be filled in with the constant pressure. Okay, so that is the abdominal pressure. We keep it like to operate any laparoscopic surgery. Remember, we keep the pressure, abdominal pressure, between 14 to 16. 14, 15, 16, whatever you like, you can keep it. Next slide, please. Next. Okay, that all this I've covered. Now coming to the insufflation. Okay, so you must be wondering, when I keep on telling like to do the laparoscopy, we put a gas inside the abdomen. Okay, so what type of gas we use? Okay, you must have heard of medical gases like oxygen, carbon dioxide, Okay, nitrogen oxide, okay, sevoflurane, all this anesthesia gases and all. So for to do laparoscopy, okay, remember two type of gases we use most commonly. Okay, first is CO2. Okay, so what we are going to do is nothing but, okay, inside the abdomen, we are going to fill the abdomen with CO2 gas. When we fill the abdomen with CO2 gas, what happens? CO2 is plain CO2. CO2 doesn't have a combustible property. Okay, but some of you might have the same doubt that why not the room air? Okay, see, remember, air contains at least 21% to 22% of oxygen. Okay, oxygen is highly inflammable. So when you put like room air inside the patient's abdomen, okay, it contains 21 to 22% of oxygen. Okay, that is going to go inside the abdomen. So when we are going to use electrocautery, or when we use something called as electrical current to perform the surgery, at that time, okay, there might be some sparks. Okay, so if we use room air, okay, so in room air, because of that oxygen, okay, because oxygen is very inflammable, that spark can be picked up by that oxygen, and entire abdomen, okay, can open up like a blast. So that's why we never use room air for insufflation. We don't use room air for pneumoperitoneum. We use pure CO2. Pure CO2 is never combustible. It doesn't like burn out. Okay, you can like operate your electrocautery without like thinking of all this busting out abdomen and all. Okay, so that's all. I think like gas is used for insufflation. We have covered. Next time. Now we don't use all this helium and all. We use only two things. Okay, one is CO2, one is room air. And room air is, again, it's a resort. Okay, it is not preference. It is always a resort. So first we start the surgery with CO2. Let's say when you are operating far away, at the same time CO2 cannot be made available. So at that time, there is this thing that you can operate on room air. Okay, but you have to take the diligent precautions. Okay, side effect of pneumoperitoneum, all these things. Yeah, we can move on to next slide. Yeah, so this is, can you just play it? This is how we put a Veress needle. Okay, that is me. That is one of my gynae fellow whom I was training. Okay, what she is doing nothing but she is lifting up the patient's abdomen, and what I showed, the Veress needle picture. Okay, she is putting the Veress needle inside the patient abdomen. Okay, once she is inside the patient's abdomen, she will connect the insufflator with the same Veress needle. Okay, so that insufflator will push. See, I'm giving the gas tube to her, so that she is connecting the gas tube to the Veress needle. Now she will put the gas inside the abdomen, and abdomen will get lifted. Okay, I think you got a broader idea. So coming to the next slide. Yes, next, fast. Go to the direct placement of trocar. So once you have lifted the abdomen with adequate amount of gas, okay, the next thing what we do is, like, as I told you, trocar. Trocar is nothing but a sheath. So go on to my slide. Next slide, please. Where, okay, so this is the exact picture. Previous slide, please. Previous slide. So this is the exact picture how we operate. We don't cut the abdomen completely, but we create a, like, keyhole incisions, and that's how we put the ports. Okay, so that is nothing but a trocar. So the next slide will show you practically how we put a trocar. Go to the next slide, please. Now play it. Okay, so she has adequately done the insufflation and lifted up the abdomen. Now, after lifting up the abdomen, now what she's doing nothing but she is putting a trocar by lifting up the abdomen. Okay. Once she is inside, yeah, going on to the next slide. So that's how we put a trocar inside the patient abdomen. Okay. There is something called as ergonomics. Ergonomics is nothing but like it is telling you how you can do the surgery without, now you must have heard like we but we are already doing like 8 to 9 surgeries per day. So if something is not correct, you will get a pain. Doctor will start having a pain. But if pain is not there, doctor can perform obviously like more number of surgeries in a day. Okay. So to do that, there is something called as ergonomics, where you can like align yourself in a way so that you can be more comfortable in performing the same surgery. The principle which keeps on telling us like how you can align yourself, okay, without facing any difficulty, that principle is called as ergonomics. Okay, but I don't think so like we should like go much more into the details of this. Like, yeah, go ahead. Yeah, go ahead. Yeah, so this is how we train our gynecologist, okay, to operate like with minimal incision. Okay, there is something called as simulators. Okay, so you can see the one chap is doing something on the simulator so that he can gain more and more of confidence of doing the same thing. Yeah, next slide. Yes, next slide. Yeah, next slide. I think the elevation angle, what I already discussed, we just slightly lift up the abdomen and then we put a trocar. That is called as elevation angle. Okay, I think like when I showed you the video, in that video, the doctor was lifting up the abdomen and then she was putting a trocar. Right? Go ahead. Next. Yes, next. Yeah, please play it. This is the one video. Please pause it once. This is the video what I wanted to show of like we doing the live surgery. This is me and this is one of my fellow whom I was teaching. So please go ahead. Okay, so this is how the same thing how we perform the open surgery, but at the same minimal invasive way. Okay, this is nothing but a uterus. We were doing some total laparoscopic hysterectomy. Okay, so it is nothing but we have put a camera inside. We have put a light source inside so that it will give us light. Okay, and we have put a pneumoperitoneum inside or CO2 gas inside so that we get a space to operate. Okay, now another set of instrument which helps us to do the laparoscopic surgery, we called it as a hand instruments. Okay, you can see the doctor performing the surgery. This is nothing but the hysterectomy. Right? Can you play it again? The same thing for my audience. Yeah. So this is nothing but a uterus. Okay, we are trying to remove out uterus through laparoscopic surgery. Yeah, right. Next slide, please. Yeah, next. Okay, so as I told you, one is camera, one is light source. Now I think like you people must have mugged. Okay, there are 3 machines which does all these things. And now coming to the surgery itself. Okay, there is something called as instruments. How we are going to perform the surgery. Those are called as operative instruments. So the same like open surgery. I think like in your BMS career or in your Unani medicine or homeopathic career, you must have been through one surgical. Okay, so inside the surgery, how in open surgery we have Alice graspers. Okay, we have scissors. Okay, we have blade. The same like that we have it in laparoscopic surgery, what we call it as operative instrument, same like that. Okay, next. Yeah, this is like graspers. I just wanted to show you the photos of the graspers. The main purpose of this seminar is like whenever you enter the OT next time, you should not feel like completely out of place. Yeah, please, next slide. Yes, there's something like how the grasper looks. Next. Yeah, grasper. Next. The same like grasper. Okay, a different type of graspers. Go ahead. Next. Again, this is the grasper. So in different what do you say, different surgeries, we have different device different graspers so that it will help us in the surgery. same like a open surgery. Okay, there is something called as vessel sealing system. Vessel sealing means like when you have a vessel, when you have a artery or vein, okay, which is conducting the blood. Okay, so what do you want? You want that blood vessel to be coagulated. Okay, so let's say you are removing the uterus. Okay, inside human body, uterus will be given some blood vasculature. Okay, so to do the hysterectomy, let's say, we have to take off that vasculature, right? So to take off that vasculature, what we have devised something called as vessel sealing. When you see a vessel, okay, you seal it, you cut it, okay, you lateralize it so that the organ of interest can be removed. Okay, so this is nothing but a picture of vessel sealing system, okay, with a grasper. Same like in an open surgery, how you must have seen. See, in open surgery, you will be having a shorter instruments. In lap surgery, we will be having a longer instrument. That is the only difference. Yeah, please go ahead. Okay, there is something called as harmonic. Okay, harmonic is another vessel sealing system. You can take it like that. Okay, go ahead next. Yeah, there is energy sources. So if you people are totally new to the electrocautery is nothing but taking advantage of electrical current. Okay, taking advantage of electrical current to perform a surgery. So when you give current through the tissue, what will happen? Heat energy will get produced. You can use that heat, okay, to coagulate the vessels. So all this, we call it as one big label, energy sources. Okay. So all this harmonic, ultrasonic, or you must have heard of bipolar, unipolar. Okay. All this comes in the same category of energy sources, which will help us doing the vessel sealing. Yeah. Go to the next. Yeah, it is bipolar dithermy. So let's not go much into the details of electrocautery. I just wanted to brief you. So go to the machine photo if you have any. Yeah, yeah. Go. Next. And of course, like coming to this thing, whenever when we talk about the surgery, let it be open surgery or let it be laparoscopic surgery, always there will be complications. Okay, so see, it will be a surgery complication. It is not because of the open surgery or it is not because of the laparoscopic surgery. So let's say inside the abdomen, okay, there is what do you say, when we talk about our point of interest, let's say it is uterus. Okay, so above the uterus, in front of uterus, I would say there is urinary bladder. Okay, backside of the uterus, there is rectum where we store our feces. Okay, so in cases of complicated cases where this urinary bladder and rectum where we store our feces, everything is othered, everything is stuck with uterus. Okay, and when surgery is posted to remove the uterus, then what we have to do, we have to separate both this thing. Okay, because we cannot remove urinary bladder and we cannot remove rectum. So when you are removing all these things, there is a chance that you might injure all these things. Okay, and patient cannot live without urinary bladder and rectum. So you have to separate all these things to remove the uterus. So when you in doing that, you might injure the same thing. Okay, the same complications can arise in the open surgery also. There is no added complications of laparoscopy to the patient, right? Yeah, next. So indications of laparoscopy, as I told you, like whenever you have a doubt that there is something bad is happening inside the abdomen, okay, then first thing what you do, first thing you guys do, because you all must have heard of sonography. Okay, what is sonography? Sonography is nothing but rather than doing some invasive, rather than putting any cut on the patient's abdomen, sonography will create an image over the abdomen, which will tell you, okay, what might be wrong inside patient's abdomen, if at all, if anything is there. Okay, in laparoscopy, okay, but let's say if like your sonography, CT scan, MRI, okay, all this will give you one idea that there might be this type of problem inside. Okay, but what is a clear cut idea? Clear cut idea will be only given by your naked eyes. Okay, so clear-cut idea. So ultrasonography, CT scan, MRI, whenever it tells you that there is like something like this, okay, so it is just an assumption. Okay, this might be the picture, but the final confirmation will be given by your naked eyes, or when you put a camera inside the abdomen and you look for yourself, okay, what is going on inside. So obviously indications of laparoscopy will be always if all your non-invasive methods like ultrasonography, CT scan, and MRI, when it fails, like what is going on, and whenever after doing all these things, also after giving conservative treatment also to the patient, if patients are not improving, then what next you can do? You can always tell them to go for laparoscopy. Okay, we put a camera inside, we just have a look. Okay, what is happening? Okay, if you find anything wrong, you will see it at that time. So that we what we call it as diagnostic. Okay, so indications of laparoscopy is all one and foremost indication is diagnostic. They will come to know what is going on inside. Okay, second will be, of course, it will be therapeutic. Next slide. So therapeutic, okay, where you go inside and at the same time you operate also. Whatever the disease is there, okay, you remove the disease also. Okay, like fibroid, ovarian cyst, whatever written, it's correct. Next slide, please. Same therapeutic laparoscopy, right? Next slide, please. Yeah. So the contraindications, you should remember, contraindication to put a scope inside any patient's abdomen will be if patients, let's say patient is very old. Okay, so he or she must be having some cardiac problems, some lung problems. Okay, so when you insufflate gas inside patient's abdomen, at that time she might develop more of this cardiac and respiratory problems. That's why the severe cardiopulmonary diseases is a contraindication. Okay, apart from that, there is like peritonitis, intestinal obstructions. These are all relative contraindication. First and foremost contraindication is cardiopulmonary distress. Go ahead, next slide, please. Complication as like all the surgeries, let it be open surgery, let it be laparoscopic surgery. Okay, it has its own complications, but I would say there is no added complication. So let's say one surgery is posted. Okay, let's say uterus removal. Okay, if you are doing open surgery, okay, and if you are laparoscopic surgery, so the difference between the two surgeries is nothing but open surgery, you put a proper cut. Laparoscopic surgery, you will go with the minor cuts. Okay, apart from that, all the complications of open surgery and laparoscopic surgeries are same. Okay, so I'm not going into details of all these things. They're the same. What I told, surgical complications is injury to viscous. Of course, like whenever you are operating, let's say in open surgery, of course, when you are operating in uterus, you can injure the bowel, you can injure the bladder. Okay, that the same thing happens in open surgery also. Okay, the same complications. Yes, stomach injury. Next, bowel injury. Next. Okay, so all this management, everything is there. My point is like, I just wanted to brief you guys about the what do you say, benefit of laparoscopy over open surgeries. Okay, next slide. Injury to viscous means injury to bowel, as I told, bladder, rectum, ureter. Okay, the same thing, the ditto same complications can arise even if you are performing open surgery. So the complications of open surgery and laparoscopic surgeries is not different, it is the same. Vessel injury, the same can happen in open surgery itself. Next slide, please. Epigastric vessels. Next slide, please. Next slide. Okay, so I would advise all of you, so whenever like if you have passed out or if you are like trainee, if you are a student in some medical college, okay, I would have always advise go to your operation theater once. If you go to your operation theater once, whatever I have told just now, okay, you will see practically. So at least go there once. Okay, be in touch with the Kishan Vidya Academy. Okay, even if you like in future, if you have developed some doubts, let's say like what is the advantage of this surgery over this surgery. Okay, now after like knowing this presentation, at least you will understand that laparoscopic surgery, it is not a high fundu surgery. It is same like a open surgery, but it's just the different way of doing the same surgery. Right? So going next. Next, all these injuries. Next, fast. Next. Yes. So I think I have covered all the major benefits and all the major contraindications and major complications which can arise over laparoscopy. But I feel like this is only a theoretical session. Okay. So when we go for practical, or next time whenever Kishan with the academy, when they plan, like when I'm operating live, okay. So at that time, when you see the same thing live, okay, automatically all these things, whatever I have told, will get impregnated in your mind. So I would always say, like, at least go to the, even if like we are not able to in next 3 to 4 months, if you are not able to plan, okay, if you can come for my surgery, but in whichever setup you are, okay, so just go for any surgery, any open surgery or any laparoscopic surgery in your medical college or in your hospital where you are like working. Go and have a look of it. Okay, you will understand what is the advantage of laparoscopic surgery over the open surgery, right? This is just the brief idea, and it is like we wanted to reduce the gap between the allopathic side, and we wanted to more empower you guys. That's why we initiated this type of discussion. I think like I have tried to cover everything. Hope minimum doubts are covered with this. Right, Jishan?
Anybody is having any doubt, you can unmute yourself
Yeah,
and
please,
answer.
please.
Requesting all of you to share your doubts, please.
I think I'm a good teacher. I think I have covered all their doubts, I think.
Sir, can we end this session?
Yeah, sure.
Give me a minute, sir. Now,
Okay. Thank you, all of you. Okay, I hope like you have a bright future, and at the same time, like be in touch with Kishan Vidya Academy. At the same time, if we get an opportunity, definitely we'll take you all of you guys to the operation theater where you get a live demonstration of all these things, whatever we have just discussed.
on behalf of all of us, we would
Hmm.
like to sincerely thank you for taking the time to present this seminar, sir.
No, I would be more than happy. I was waiting for this, and thank you so much, Kishan Vidya Academy. Like they have done something what we always wanted. Okay, so there is nothing called as Ayush medicine. There is nothing called as allopathic medicine. Okay, in India, okay, everything comes to like we have to bridge a gap. Everything at the same time we have to stand out as a doctors together. Okay, so you people are better in some way. We people, we think we are better in some way. Okay, let's like gather up and share each of our knowledge, and we can use it for the best of our patient, I feel.
And we thank you once again for your valuable time and sharing your expertise with us, sir. We hope
Sure,
to have the opportunity to learn from you again in the short future, sir.
sure, definitely. Thank you so much.
Thank you, sir.
Okay,
Thank you very much.
have a good night. Good what do you say, Ganpati Nimarchanam.
Thank you, sir.
Thank you.
Thank you all. Thank you.